subscribe now and press the bell icon. Never miss an update.
Hello and welcome to Health Live at Seniors Today. We are here on an August Saturday, and that is the 5th of August, and we have here with us Dr. Mudit Khanna. Dr. Khanna has been there with us, was there on Health Live at Seniors Today in February 2022. He is a leading consultant in orthopedics, trauma and joint arthroplasty, which is joint replacement surgery, and with the Wockhardt Hospitals in Mumbai. Dr. Khanna graduated from the prestigious King George's Medical College in Lucknow, from where he completed both his M.B.B.S and M.S. in orthopedic surgery. Most of his higher surgical training in orthopedic surgery has centered around gaining expertise in the field of joint replacement surgery in the United Kingdom and other reputed centers across Europe, the US, and Australia. While pursuing his higher surgical training in the field of orthopedic surgery in the United Kingdom for a period of 5 years in various capacities, he completed his M.R.C.S from the Royal College of Surgeons of Edinburgh in the UK and the M.Ch in orthopedic surgery from the University of Dundee in Scotland. He has worked as a senior clinical fellow at the Queen Elizabeth Hospital in the UK and was awarded the Asia Pacific Zimmer Fellowship, which he pursued at the renowned Cleveland Clinic in Ohio in the US. He has expertise at performing all forms of primary and revision joint replacement cases and is a trusted name at handling complex sports-related injuries requiring arthroscopic treatment. Dr. Khanna has a number of national and international publications and presentations to his credit. He is extensively into teaching and is a faculty across 7 training programs aimed at aspiring arthroplasty surgeons. He has authored 2 highly rated books in the field of postgraduate studies. His work has been acknowledged by leading medical publishers, and he's a member of the Royal College of Surgeons at Edinburgh and the Indian Orthopaedic Association. We are so happy to have Dr. Mudit Khanna once again. As I mentioned, he was there with us in Feb 2022, and we invited him to speak once again. And thanks to the Wockhardt Hospitals to facilitate this. Dr. Khanna, how are you doing?
So I am good. First of all, thank you very much for a lovely introduction.
Thank you very much, Doctor, for joining us. And coming. I hope you were driving. There was not too much traffic, thankfully, in your part of Mumbai.
No, it was very close. It's just 2 minutes away, but you never know traffic, but it wasn't too bad. So I hope I haven't delayed everyone by too much. And I'm
not
happy
at all,
to.
Doctor. Thank you for joining us. So without further ado, we have invited Dr. Mudit Khanna to talk about arthritis care for senior citizens. Now, as we know, this is a common issue, common problem with a lot of seniors. So, there could be no better person than Dr. Khanna to speak about it. So, as always, please put your questions in the Q&A tab, mention your age and your gender. We may not be able to talk specifics about medicines, etc., but do ask the question and you have an opportunity of a lifetime where Dr. Khanna is in the house and you can ask some questions, of course, unfortunately via me. Thank you. And over to you, Dr. Khanna.
So I've just pressed share screen. I think I'm waiting for your permission to share my screen.
Yeah. Sorry, I'm just getting it done. Yeah, you can share the screen now.
Okay.
Yeah.
Oops, so not very good at technology, but I think let me just put this on presentation mode. Okay. So is the screen visible to everyone?
Yes, it is visible. Thank you.
Okay, perfect. So I think let me start off first by explaining what arthritis is, and let's try and understand what arthritis is, because it's a very, very common condition. It's a very common problem. It's something that 7 or 8 out of 10 people out of 7 or 8 out of 10 will have by the time they reach 70 years of age. we are definitely getting younger by the day. There was a time when we were 60 and we would say that life is almost over. And we are at a stage where we are 70, and that's when we start planning what all we need to do, because that's when we start getting time for ourselves. So I think aging as a process has changed significantly. We are living much better quality of life for much longer, and therefore taking care of our knees becomes all the more important. Plus the fact that since we are living longer, we are facing more of arthritis issues. So it's best to know how we can deal with arthritis in the best possible way. I think in the last talk that I did, I talked more about the replacement part. So I'm going to give that a back seat. The objective of this presentation is to explain what arthritis is and look at what factors are in our hands to reduce the incidence of arthritis. So let's understand first what osteoarthritis means. Now, arthritis is a broad term. Arthritis in the most simple terms means loss of cartilage in a joint. So let's again go back and look at two common terms that are used. And the two common terms that are used are osteoarthritis and osteoporosis. And a lot of people tend to mix these two terms up. Osteoporosis, as the name suggests, has two parts: osteo meaning bone and porosis meaning porous. So porous bones is osteoporosis, which essentially means weak bones that happens as we age. Osteoarthritis, a probably somewhat similar sounding term, means osteo meaning bone, and arthritis meaning loss of cartilage in the joints. So anybody who has pain in their joints, and joints is that part of the body which moves. So for example, an elbow is a joint, a shoulder is a joint, a knee is a joint, a hip is a joint, but the bones in the arm, in the forearm, in the thigh, in the leg, these are bones, these are not joints. So a joint is a place where two bones meet and movement happens. Now, wherever in the body two bones meet and movement happens, there is a cushion known as cartilage that surrounds these bones. And wearing out of this cushion or wearing out of this cartilage over a period of time is known as arthritis. Now, osteoarthritis is a term used when the cartilage is slightly worn out, which may happen in people when they're in their sort of early 40s. It may happen younger, it may happen later, but typically osteoarthritis or wear and tear arthritis starts when someone starts in their about 40s. And as arthritis progresses, this cartilage progressively thins out. So if we look at this image, this is a cross section of a bone. We see a bone and then we see a layer of cartilage on top of it. In the figure on the next, on the right, we see that the cartilage is slightly worn out, but quite a bit of cartilage is still intact. In the third image, which is below, we see that almost the entire cartilage is lost. And in the fourth image, we see there is no cartilage available. So this would be normal progressing to grade 1, 2, 3, and 4 arthritis. What we are worried about essentially is bone-on-bone arthritis, or arthritis where the bone at the top starts grinding with the bone at the bottom, which is what we need to delay, which is the objective is that we don't reach there, or we reach there as late as possible. So the idea of preventing osteoarthritis essentially means preventing the progression or delaying the progression of arthritis from grade 1 to grade 4. Now, this is just an example to show what arthritis means. Just like a car tire will wear out at some point, just like the sole of a shoe will wear out at some point, and in the same manner, the lining of the joints or the lining of the bones at a joint will wear out. Now, osteoarthritis in Indian patients is most common in the knee. The knee is the most commonly affected joint in the Indian population. It is not true across the globe, but for our relevance, the majority of patients that we see suffering from arthritis are those who are suffering from osteoarthritis of the knee. The typical symptoms or the typical presentation starts with pain. The pain is initially only after a period of prolonged inactivity. So somebody is sitting on the dining table on a chair for half an hour, 45 minutes, gets up, finds it difficult to take the first few steps, and then is all right. That's the initial symptom. Or people are uncomfortable or have pain in their knees after a prolonged journey in a car. So getting in and out of the car gets difficult. Or let's say going up and down the stairs becomes difficult. So that's how arthritis typically starts. And that's the time we need to realize that, we need to probably check whether everything is okay with our knees, or are we truly developing arthritis? This is the initial symptom. As arthritis will progress towards grade 4, we start seeing other things like deformities. So we can see somebody with a bow legs, or we can see somebody with knock knees, as is visible in this image. That's when arthritis is already bad enough, has reached grade 4, and these patients require a surgical procedure in the form of a knee replacement to get them back to work. Now, just to play a short video, if we see this gentleman here, we can see that he's got obvious bow legs. He obviously has pain. So he has pain, he has deformity, and he is in visible discomfort. I don't even need an X-ray to say that this gentleman is suffering from grade 4 arthritis of the knees and is bad enough to need a permanent solution in the form of a replacement. If you see another gentleman who has probably managed for a much longer period, again, it's not a very pleasing video, but we can see that the knee is not taking the required load, and this needs to be tackled surgically. Now, the whole idea is that the whole idea of the talk today is to see what we can do to delay the progression of arthritis and prevent us from reaching this bad stage where we require a replacement surgery. So when we look at risk factors for arthritis, there are factors that we can do something about, and there are factors that we cannot do anything about. So we cannot do anything about the fact that we are aging, though osteoarthritis is not directly related to age, which age is a very important risk factor. Most people develop arthritis or wear and tear as they grow older, but there's nothing we can do about it. It is more common in women than it is in men. So unfortunately, women are on the riskier side of developing osteoarthritis. And it's and our race plays a role. Thankfully, us as a race only have arthritis in the knees. If you look at the Western population, they have equal amount of arthritis of the hip, of the knees, of the shoulders. You see a number of patients in the West who've undergone both shoulder replacements, both hip replacements, both knee replacements, because they have a high incidence of arthritis affecting the other major joints. But we have arthritis primarily limited to the knees. Now, these are three factors that we unfortunately cannot do anything about. But if you look at the modifiable risk factors, which means factors that are completely in our hand, these are the ones that we need to focus on. So the three modifiable factors and the three factors that we really need to focus on is A, our body weight. So we will come to it. So I'm just going to highlight them, and then we'll go and move on to each one of the following. So your weight is the single most important risk factor in determining how soon you are going to develop osteoarthritis of the knee, provided you are at risk of developing arthritis. How weak your muscles are is the second most important risk factor in deciding how soon somebody will develop arthritis in the knee. And if someone has had an injury to the knee, a ligament injury, a shock absorber injury while playing sports, and they never got it looked into, they have been managing for a long time despite the injury, without proper treatment, then these patients are likely to develop arthritis in the knees. So what do we need to do? We need to make sure we are as close to an ideal body weight as we can. We have to make sure that we exercise regularly to maintain good muscle strength. And if we do have an injury that is been troubling us for a long time, but we are still able to manage, we shouldn't be ignoring such an injury. We should be having such an injury looked at. So coming back to the first modifiable factor, which is losing weight, let's try and understand how important weight loss is. And let us understand that it's every kg that counts. So when somebody is on a single leg stance, for example, it is about 8 times the body weight, stress equal to 8 times the body weight that goes across the knee, which means if you lose 1 kg of body weight, you save 8 kgs of stress on that knee, which also means that if you lose 5 kgs of body weight, you would lose 40 kgs of stress going across the knee. Now that's a huge amount of stress that you can reduce by losing weight. So I think the reason to stress on this slide primarily is to highlight the fact that if you are ending up losing 1 kg or 2 kgs, it's a lot to be happy about, because every kg is counting to reducing or delaying the arthritis. Now let's look at what guidelines recommend in terms of how much one should lose and how rapidly one should lose this weight. So all existing guidelines recommend that our initial aim should be to lose 5% of whatever we weigh, provided we are overweight. So if somebody is 80 kgs, he is looking at losing about 4 kgs to begin with. And how fast, which again becomes important, because we don't want to suddenly lose weight and then sort of gain that weight back after a month. So no crash dieting, no sort of things that are temporary. We are aiming to lose a reasonable 1 kg in a month, which means that if I want to lose 5 kgs of body weight, I'm looking at 5 months or 6 months to achieve my target. And that will allow me to maintain that body weight. That will allow me to lose it in a way that I don't regain that body weight. And that will allow me to maintain a healthy weight for a much longer period of time. Now, what is the evidence to say that this weight loss makes a difference? So I'm reading out 2 lines that are from index journals. For a woman of normal height, weight loss of only 5 kgs reduces the risk of developing osteoarthritis by more than 30%. That's huge. It is estimated that substantial weight loss, example, obese to overweight or overweight to normal weight, could prevent 33% of osteoarthritis in women and 20% of osteoarthritis in men. Again, it's 1/3 of the burden of disease that we can reduce, or by just moving one category down. We're not even talking about obese to normal. We're talking about obese to overweight or overweight to normal. Okay, so again, this is the AOS, or the American Academy of Orthopaedic Surgeons, and NICE stands for National Institute of Clinical Excellence, UK. So both the American and the UK bodies recommend that we lose a minimum of 5% of body weight and maintain our weight at that level with good dietary modification and exercise, and that could reduce the burden of osteoarthritis by up to 33%. Now, how to lose weight? Again, a very, very difficult question, but in a nutshell, it's very straightforward. Weight loss is always a function of diet and exercise. I am no one to advise on what kind of diet and what kind of exercise, but we'll talk about, we all understand that it has to be a combination of diet and exercise. And out of diet and exercise, we all agree that diet plays a more significant role than exercise does when it comes to weight loss. The second important part, which is in our hands, is exercise. And one of the questions that is often asked by patients who come with osteoarthritis knee is that sometimes they end up seeing some doctor who tells them that, listen, you've got arthritis in the knees, and therefore you should stop walking, you should stop all forms of exercise, otherwise you are going to damage the knee even further and much faster. Okay, but every existing guideline has disproved this theory. It has been very, very clearly established that joint friendly exercises actually help delay the progression of arthritis. So stopping exercises is not recommended when somebody even has grade 4 or established arthritis. What kind of exercises? We will be coming to that. But in a nutshell, if somebody asks you to stop walking, or to stop your aerobic exercises, or to stop your stretching exercises just because your joints are paining and you are beginning to develop arthritis, please don't listen to that advice. As the last line reads, it is better to wear out your joints than to rust them out. Arthritis is going to get worse over a period of time, but not exercising is going to make it worse faster rather than slower. So again, a line quoted from the guideline: in the absence of a cure, joint-friendly exercises is the single most important weapon in the fight against osteoarthritis. So what kind of exercises are we really talking about? Now, there are 3 sets of exercises that we want you to focus on. One is muscle strengthening exercises, which means exercises to strengthen the muscles that support our knee, which is essentially your quadriceps, which is the muscles in the front, the hamstrings, which are the muscles in the back of the knee. The stronger the muscles are, the more load that is being transmitted to the bones and the cartilage in the knee is going to be absorbed by the muscles, and lesser load is going to go on the cartilage. So the stronger the muscles are, the less load is transmitted to the cartilage, and therefore the progression of arthritis is going to be delayed. The second most important set of exercises is range of motion exercises, yoga, for example. So an arthritic knee has a tendency to become stiff. It has a tendency to, it is more painful to completely straighten the knee. So a lot of patients stop completely straightening the knee, and it is very painful to completely bend the knee. So a lot of people just are happy to bend it to 90 degrees or 100 degrees, and then they stop bending it more. Now, if you lose flexibility or if you lose range of motion across the knee, then you lose a lot of abilities. For example, if the knee becomes locked in 10 degrees of flexion, or it doesn't straighten fully, it is like you standing up with the knees bent 10 degrees. I think, if I were to stand up today and keep my knees bent to 10 degrees, I wouldn't be able to stand for longer than 10 minutes. And if I lose the ability to bend my knee completely, then it is going to be extremely difficult for me to get up from a low seating position, because unless I get about 110, 120 degrees of bending in the knee, I will not be able to stand up from low seating. So please make sure that you maintain the range of motion with pain or without pain. The fact that someone is getting pain on deep bending or complete straightening should not prevent them from completely bending the knee or straightening the knee, thinking that the pain will get aggravated or that the arthritis will progress faster. And the third is obviously your standard aerobic exercises, your walking, which is primarily there to help in weight loss, which we have already stressed about. How much of exercise is recommended by guidelines? It's about 150 minutes or 2 hours and 30 minutes of low to moderate intensity aerobic activity every week. And it should be performed in episodes of at least 10 minutes and should be spread throughout the week. So if somebody wants to walk for 30 minutes, they can, and they find it difficult to walk 30 minutes at a stretch, they can walk 3 times, 10 minutes each and reach their 30-minute target. But about 2 hours and 30 minutes in a week is the minimum that somebody should focus and maintain. In terms of tips, no significant tips, except don't be a weekend warrior. Don't just get up tomorrow and go for a 2-hour walk when you haven't been walking long enough. The rule is, it's a rule of 10% increase from whatever activity of exercise you're doing. Go slow into increasing it by not more than 10% a week, and try and give rest to one part of muscles in between in a rest day. So work one set of muscles on one day, give them rest the next day, work on the rest day, give train some other set of muscles, and then come back to the initial muscle the next day. The third part, which we talked about modifiable factors, was treating an injury. So a lot of the times someone ends up being involved in a sport, slips or falls down, misses a step, and then they have some pain in the knee, some pain and swelling. Like all of us advise, we rest it, we ice it, we give it some compression, and we wait it over. In 2-3 weeks time, we feel that we've recovered from it. The pain has gone much less. Now, in 8 out of 10, we probably did not have a major injury, so we recover completely. But there will be 2 out of 10 people who had some major injury in the knee, which is not visible on an X-ray, because the X-ray is only capable of looking at bone. It doesn't look at the supporting structures of the knee. It doesn't look at the ligaments. It doesn't look at the muscles. It doesn't look at the tendons. So if someone has had an injury 3 weeks or 6 weeks ago, but still continues to have pain in the knee, they should get it shown to an orthopedic surgeon, maybe get an MRI done. An MRI is an investigation that can look into the soft tissues, into things, into ligaments, into supporting structures of the knee that an X-ray cannot look into. So just to show you a few images of what we can find if you look inside these knees. Normally, the cartilage, if you put a camera in the knee, and this is a scopy visual, which means we put a camera in the knee, what you see at the top is the bone at the top. What you see at the bottom is the bone at the bottom, and you can see it's absolutely pristine, smooth. This is how we want our cartilage to look. Now, sometimes we look into the knee and we find the cartilage with such fibrillations like this. Sometimes we can see cracks in the cartilage, and if we don't address these cracks right away, then these are going to peel off the entire cartilage like the skin peel off an orange. So if we can identify them early, we can treat them early. We don't want a crater like this to be developed with surrounding cartilage intact, because this is exposed bone, and this bone is going to be painful. So there are multiple such things. Sometimes you've got a loose body hanging in the knee, which may come between the bones and then cause more damage to the cartilage. So the third important point, as I said, is to treat an injury, especially if that injury has been troubling us for a long time. We've given it 3 weeks or 6 weeks. We've given it the time it takes for a normal injury to heal. But if it has not healed, don't just completely ignore the injury. And then in terms of a number of things that are coming up new, in terms of treatment, in terms of regenerative medicines. So we're talking a lot about orthobiologics now. Orthobiologics is a completely new field where we are trying to sort of supplement the body's ability to heal from natural injuries. And this group encompasses things like platelet-rich plasma, growth factor concentrates, the entire thing about stem cells. So basically, it's a procedure in which we support or supplement the body's ability to heal by providing them growth factors or healing factors from their own body. In the most simplest terms, it's a treatment wherein blood is drawn from one's own blood. It's then sort of treated with multiple methods in multiple ways to separate out the growth factors or healing factors and those healing factors or growth factors are injected back into the knee or the site of injury to help in the regenerative process, because anything that degenerates is always when the balance between degeneration and regeneration tilts towards degeneration, it degenerates. If it tilts towards regeneration, it regenerates. Now, we cannot offset a huge amount, but we can definitely reduce the rate of wear by providing these regenerative factors with regenerative medications. And this is just a list of all these factors that come in. And I think that is where I would like to stop. I wouldn't want to go into the details of arthroscopy. There is a lot we can talk about in terms of replacements, in terms of robotics that have come up, in terms of computer navigation. But I think since the essence of the talk today was to primarily talk about what factors can help prevent arthritis, and so I'm trying to refrain from sort of talking more about the replacement procedure itself.
Thank you very much, Doctor, for this very detailed presentation. We have quite a few questions that are coming. Shall we take the questions now, Doctor?
Yes, of course, I'm ready.
So before we continue, as I mentioned to you, this is Dr. Khanna's second session with us, and the chat window here, I have put the link to his first session. So those of you who would like to see it can look at the session that was there. It has the takeaways as well as the video. You can watch that. And of course, this session will be there. Some of you may not have made some notes. Some of you may want to see it once again, the presentation and some of the answers, responses that Dr. Khanna gives. So you can have a look at the edited video on the Seniors Today website, that is seniorstoday.in, on Monday evening. You can do that. In the meantime, I'll get into questions. We have a question from Mr. Devendra Ganguly, who says, I'm a 62-year-old male diagnosed with the Dish syndrome. How does that affect my future?
Okay, so I mean, I think we will have to leave this question for a completely different day. Dish is basically a syndrome that is associated with the back, and I think it's not within the context of osteoarthritis. But having said that, physiotherapy remains the main course of treatment, and I think the best person to advise you on this would be someone who specializes in the spine and can give you sort of more insight into what options are available.
And we will do a session on spine very soon. We have a question from Mr. Om Kumar. His question is, what is 3D knee surfacing surgery? Is it good for mild to moderate osteoarthritis?
Okay, so to answer this question, the first thing that I can say is that I don't know what 3D knee resurfacing surgery is. Okay, so I think if you ask me within its existence whether there is a 3D knee resurfacing surgery, no, there isn't a 3D knee resurfacing surgery as a procedure listed in any of the procedures or in any of the books or in any of the existing guidelines that exist. Now, a number of times, it's the same procedure that is defined in a different way by a different surgeon. So I think, now I don't know whether the surgeon whom you've seen talked about resurfacing the 3 compartments of the knee, or he talked about the use of a gel, that again, regenerative part where you put in a camera and you find the areas where you've lost the cartilage, and you use special liquids, special gels that sort of tend to resurface these areas of the knee. What that involves is basically using special gels that stick to the bone, and then you have to stay without weight bearing for a certain period of time, often 4 to 6 weeks, for some kind of fibrous tissue to form there. So the normal cartilage does not resurface or does not reappear, but there is some covering that happens on the bone, which helps in delaying the progression of arthritis and reduces pain, because now you do not have any more exposed bone. But essentially, there is nothing as a terminology where of a 3D resurfacing surgery.
Thank you. We have a question from Mr. Ravi Gandhi, who says, after 60, is it recommended to have calcium? He is 62 and from Delhi.
So see, the answer is objectively, if you ask about, so it would slightly differ between males and females. In females, we do recommend calcium, especially after menopause, because of the hormonal changes that go across in their body. And therefore, they often end up having weaker bones, and calcium is recommended. For men, essentially, the best way to decide whether someone needs calcium or does not need calcium is to look at their bone strength. So there is a test available, which is known as bone densitometry or a DEXA scan. A DEXA scan actually can tell how weak or how strong your bones are in comparison to someone normal of your age. And if you find yourself either osteopenic or osteoporotic, then you need calcium supplementation plus minus other medications. Calcium by itself, just to take calcium because somebody else is taking calcium, is not necessary. What we have to understand again is that while vitamin D is checked on a blood test, which means you take a blood test, you check your vitamin D levels. If it comes low, you can take medications. You cannot check calcium levels by checking your blood calcium levels, because bone essentially is the bank of calcium. So whenever blood calcium falls, blood borrows that calcium from your bone, and blood calcium is returned back as normal, while your bone calcium is going down. So whenever we want to check a deficiency of calcium in someone's bones, we don't do a blood test to check calcium. We do a bone densitometry to see how weak or how strong someone's bones are, because whenever you do a test, even with extremely weak bones, you may have a blood test that shows normal calcium levels.
Thank you. We have a question from Mr. Mudit Khanna. He is 71. His height is 5 feet 9 and his weight is 89. He is suffering from pain in his right knee for the past decade. He used to be a good table tennis player, and due to excessive playing, he developed the pain, and which was diagnosed as meniscal tear. I managed with exercises, he says. If knee replacement is a must, is proper body weight a must before undergoing the surgery? Some people say the surgery is very painful and it can take months to recover. What will be the approximate cost of the surgery?
Okay.
After surgery?
Yeah, so I will answer it in short. So let's understand two things. Meniscus is a shock absorber of the knee, and when we said treat injury so that you don't develop arthritis, what we meant essentially was, if this meniscal tear was taken care of at the time when you developed the tear, you might not have progressed to arthritis requiring a replacement. Now, anybody who has a meniscal tear, meniscus being the shock absorber of the knee, we try our level best to preserve the meniscus, which means we try to repair the meniscus and hold it in place so that the shock absorption in the knee continues to take place normally and the stress is not passed on to the cartilage, and therefore cartilage does not wear out. Earlier, people to treat meniscal tears often removed the menisci, which they took care of the problem at that time, but actually led to an increase in the incidence of arthritis. So that's something that we do not do now. We try not to do now, but now we try to repair the meniscus rather than removing the meniscus. Having said that, if you've been extremely active without a functioning meniscus, then obviously there is a chance that you may have developed arthritis, which is grade 4 and requires a knee replacement surgery. So a knee replacement surgery is an extremely successful surgery at the moment. if you ask me what is the biggest change that has happened in a knee replacement surgery, I think it's the way we manage pain around the knee replacement surgery. So from being a very, very painful procedure, it's gone to an extent where we actually label it as a painless procedure, where I wouldn't want you to confuse it with painless, but pain space less, which means less pain procedure. It's if you look at a subset of, if we score pain on a scale of 0 to 10, 0 being no pain and 10 being really bad pain, majority of patients have a pain score between 0 to 3 after the surgery. So it's nowhere close to being bad in terms of being 7, 8 or 9 or 10 out of 10 on a pain score. Majority of patients, 95% of patients will have pain within 0 to 3, which by all means would be rated as mild. Yes, complete recovery does take time. So the minimum time that I would say for someone to recover from a surgery is about 3 months. And you continue to recover even after. Having said that, there is no period of bed rest. There's not a single day of rest. If the surgery is done in the morning, we allow you to start standing, walking, bending, straightening, everything from day one. People start using the washroom from the second day. People start climbing from the stairs from the third day, and they go home on the fourth day. There are patients of mine who, recently he had come, there was an international patient who has been regularly participating in events where he cycles for 400 kilometers after a replacement. So it varies from patient to patient. Pain is a very subjective feature. I might hold a small needle on someone and someone might just jump off the roof and someone might just not even wince. But in a nutshell, it's not a very painful procedure. A lot of things have been done to reduce pain around the surgery. I do agree it used to be a painful procedure. So find a good center, a dedicated center, a center of excellence that is doing surgeries, keeping the pain management in mind, because that's on top of priority for all of us joint replacement surgeons at the moment.
Thank you very much. And to all of you over here, while Dr. Mudit Khanna is at the Wockhardt Hospitals in Mumbai, you can also get in touch with him via the hospital. And I'm sure the hospital has some provisions for doing a teleconsult, etc. But we have, I know we are getting close to 6 o'clock and we end it normally at 5:45. Just a couple of more questions, Doctor. One is,
sure.
Dalaji asks, Doctor, will climbing stairs be detrimental for our knees in the long run, and will wearing kneecaps help?
Okay, so now it depends on whether someone does have bad arthritis or someone does not have bad arthritis. Climbing stairs is so while we need, in terms of recommendations, if someone has established osteoarthritis, what we recommend in terms of joint friendly exercises is walking, cycling, swimming, elliptical or a cross trainer. These are exercises where one foot is on the ground at all times. These are low impact activities and they do not harm the joints whatsoever. Climbing stairs and sitting on the floor are debatable issues. I would not recommend someone who has moderate to advanced arthritis to climb stairs or to sit on the floor frequently as a form of exercise. But in case they are going somewhere where they have to do it, I wouldn't refrain them or stop them from doing it. If someone wants to be active and stay active as a form of exercise, cycling, swimming, walking, and the elliptical are the best things to do. If someone stays on the second floor and has to climb down to do his walks, to do his regular activities, then I wouldn't stop him from going up and down the stairs every day.
Right. And do glucosamine tablets help seniors?
So it's a debatable thing. If you look at the American Academy of Orthopaedic Surgeons guidelines, and if you look at the NICE guidelines, I will state what they say. They say that there is no role of glucosamine and or chondroitin sulfate in the management of symptomatic osteoarthritis. So these are lines quoted both from the AOS guidelines and the NICE guidelines. The American League Against Rheumatism is another body that issues guidelines. They have gone neither in favor nor against glucosamine and chondroitin sulfate. So it's in the most simple terms, I would say do not expect glucosamine and chondroitin sulfate to do any wonders on the knee. Personally, I don't prescribe glucosamine and chondroitin sulfate to any of my patients. But if any of my patients are on glucosamine and chondroitin sulfate and they feel they are getting better with it and they feel that it is helping them, I do not stop them from continuing it. So they are not harmful, but they are not really recommended by existing guidelines, and that's the reason I don't prescribe them. Majority of patients have kids living in the US. They're classified as nutritional supplements. These kids get big bottles with, I think, 1,000 tablets each back home for their parents, and that's how they are used. To use them as an expensive medicine in India is not something. It's a supplement. It's a nutritional supplement with very limited value.
Right. Thank you, doctor. We have a couple of questions. One is, which I would like to look at. One is, does cell therapy help for knee osteoarthritis regeneration?
So cell therapy is something that we've been working on for a very, very long time. We've been looking at cell therapy for about 10 years now. And we've had some very good results, some good results. And overall, but again, we need to understand the right patient selection for a cell therapy. So cell therapy is part of the regenerative thing that I mentioned during the talk, where we're trying to regenerate cartilage. Now, to regenerate something, you need to have some cartilage remaining. So if we were to divide arthritis into grade 1, grade 2, grade 3, and grade 4, the least role of regenerative therapy or cell therapy is in grade 3 and 4. And the maximum role of cell therapy is in grade 1 and 2. Now, the problem that we face is that majority of patients that we end up seeing are already grade 3 or grade 4. And that's when they are looking for regenerative therapy or cell therapy, where it has the least amount of role. And most patients in grade 1 and 2 sort of ignore their symptoms and carry on with it, don't look after their knees, and present to us only once they're already grade 3. So in early osteoarthritis, it has a significant role in delaying the progression of arthritis. But in advanced osteoarthritis, it probably has very, very limited role, if any.
Thank you, doctor. Just one last question, and this is not about the knees. This is from Mr. Bharat Mehta, who's 66. He says, sometimes while writing or working, my fingers become very stiff. The difficulty in moving, what is to be done for this stiffness on the finger?
Well, the treatment for so there could be multiple causes of it, and one of them could be neurological. But essentially, if you talk from an orthopedic point of view, every stiffness has to be countered by movement. So the best treatment for stiffness is to do the exact opposite, to keep moving the fingers every now and then. Maybe take a smiley ball, maybe take a piece of wet cloth, dip it in warm saline, cold water, any water, and keep the fingers moving. Don't let them be in one position for a long time. And that's true for any stiffness, any arthritis that is arising from inflammatory pathology of the joints or the bones.
Thank you very much, doctor. There are a few questions that have been left unanswered. It's just that we've crossed 6 o'clock, and we never really go that far in terms of time. Thank you very much, Dr. Mudit Khanna, for taking some time out. And I know you were in the hospital, and this is a Saturday evening. Thank you very much for your time. Thank you to Wockhardt Hospitals to facilitate this. We will be back once again next Saturday at 5 p.m. for another session of Health Live at Seniors Today. The topic that we are talking about is medication of overload and polypharmacy. That is the topic for next week. If you want to participate, if you want to attend rather, the health webinars. You can pre-register. The link was there in the chat window. Attend, just pre-register, and we will have you on. Remember to download the Evergreen Club app, which is our new home for all our events and activities. The Seniors Today website is, of course, available, and all our health webinars are there on the Seniors Today website from the very beginning, from June 2020 is when we will be having this. You can also have a look at the session that Dr. Mudit Khanna had done in February 2022, and the link, of course, I had put over here. Thank you very much once again, Dr. Khanna. Have a great weekend, and to all of you also. Have a good weekend, and we'll be back again next Saturday at 5 p.m. Thank you very much.
Thank you very much for having me over. Thank you.
Subscribe now and press the bell icon. Never miss an update.